Hi, my name is Jaron Chong and I'm a body radiologist from Victoria Hospital in the Department of Medical Imaging. This presentation is about medical imaging logistics and will offer you general advice and tips on how to communicate with medical imaging and radiology as you begin clerkship. During clerkship, you may be called upon to perform various tasks that will interact with radiology or nuclear medicine, from the fairly common task of ordering an imaging examination to various steps following that order, including advocating for a scan to be performed more urgently, getting a preliminary result before an official final report, following up on or clarifying results on a report, or performing these same functions outside of business hours during weeknights or weekends on call. Over the course of your duties as a clerk, you'll of course be receiving guidance and supervision from your medical or surgical teams, residents, and staff. What this presentation aims to do is to give you some advice on how to perform these functions effectively and give you some advice on how to best do the job for your teams. By far the most common interaction you will have with medical imaging, whether now in clerkship or well into residency and clinical practice, will be ordering a medical imaging examination. Just as with making an order for a medication or admission, ordering an imaging examination usually comes in the form of instructions entered either with a computerized order entry or in a primary care practice or clinic, a paper form requisition. Regardless of the precise method that you use to make this order, there are common themes that exist independent of order method. While the majority of order entry work performed at LHSC is computerized, you may eventually encounter forms that look like this. Much of this form is somewhat self-explanatory, such as the section in the top right that asks you to identify the patient, or the middle section that asks you to identify yourself or the staff that you're working for. But you'll notice that there are two very large sections at the bottom. On the left, number one, that asks what radiology examination is being requested, and number two, the clinical history to the examination, so-called the what and the why. Other forms can be complex. For example, this form for a CT scan requisition for Southwestern Ontario, or a general radiology requisition from Woodstock Hospital. These forms may more ask questions about the patient, including pre-existing medical conditions, but invariably they will always contain a section about what exam is being requested and have a section covering either clinical information, clinical indication, or clinical history. That is again asking why is the exam being performed. In the inpatient setting at LHSC, the electronic health record system is from a vendor named Cerner with the primary system called PowerChart. You'll gain experience of this EMR system formally by watching and learning your team enter orders per patient. But very often, when you place orders, there will be a keyword you have to search for. In this example, the keyword abdomen. And you can see various filtered options to order X-ray exams of the abdomen. Notice that there are many abbreviations that may ask for the examination to be performed in various positions, portably, or in the example of a series, multiple images taken. These are the order search results for the keyword chest, which results in various options for a chest X-ray, again with options for indication, stat priority level, decubitus positions, images in maximum inspiration or expiration, and so on. Once you select the examination you wish to order, you'll be presented with a form that looks like this. Again, just as with the paper forms, there is always a section on what exam you're ordering, in this case an X-ray of the chest in posterior anterior PA view and lateral view from the side. And just like the paper forms, there is a text box to fill out labeled reasoning for examination or clinical history, which summarizes essentially the clinical situation and the primary question or problem you wish to solve with this exam. That single line is included at the top of every radiology report and gives the clinician the opportunity to guide the radiologist towards the question or problem they have in mind. When you're placing your very first imaging orders, often you'll be told by your supervisors precisely what to type into that clinical history text box. But it's important for you to understand what makes for a good clinical history and what is helpful about that history to us in radiology. The number one thing you should try to do in a good clinical history is to come to the exam with a specific question, a best guess diagnostic hypothesis, or if the clinical situation is unclear, a specific symptom or location of symptom. Ordering an exam is never just about performing an exam for the sake of doing it, but must ideally be paired with a specific question or problem you're trying to solve. If there is a specific side or location to pain or symptoms, specifying where those symptoms are can help guide us to focus the exam. If the mechanism of injury is traumatic, specifying the mechanism of injury, be it a high-energy blunt traumatic injury like a high-speed motor vehicle accident, or a traumatic injury like a wound puncture or laceration, can affect the list of possible diagnoses made or the protocol we use to perform the scan. If there is a medical history that is oncology or cancer related, knowing the specific type of primary cancer history can influence where disease is most likely to metastasize, as well as which sequences show metastases most accurately. Finally, if a specific surgery has been performed, knowing which surgery specifically can influence whether what we find in the image is immediately actionable or not, or influence what specific complications are likely to occur in the immediate postoperative setting. These are examples of clinical histories that you could see at the top of a report. When you first start clinical service, many of the abbreviations and acronyms may be unfamiliar to you, but over time you'll become more and more familiar with what they all mean. CP for chest pain, SOB for shortness of breath, MVC for motor vehicle collision, SBO for small bowel obstruction, or PPD for purified protein derivative to test for TB. The abbreviation R/O for rule out is often used to ask us to exclude a specific diagnosis. Notice that these histories are often not very long, but they are generally quite specific, and they give us insight into what you're thinking of is the main problem with your patient. Many of the other tasks you have to perform with medical imaging, radiology, or nuclear medicine often concern communicating with us in some way. Precisely what about will depend upon what has already happened with your patient and whether a scan is yet to occur or has already been acquired. Oftentimes, you'll be asked to contact radiology to advocate for a scan to be performed faster or to figure out when a scan ordered will occur. The scan may have already occurred and you'll want some preliminary results more quickly. You may have had a final report, but there is a specific question that has not been answered by the report that you want clarified. Finally, you may want to perform any of these above tasks, but during on-call after hours. The first thing to understand about medical imaging is that we operate differently, whether you're in normal business hours, usually 8 a.m. to 5 p.m., versus after hours on call, which would be post 5 p.m. or on the weekends. During routine daytime work, our departments are divided into services or stations where specific staff and residents are responsible for a particular body system or set of examinations or procedures. In the after hours, a smaller part of the department is responsible for all urgent examinations performed overnight, which can sometimes be a small team of 1 to 3 residents covering University, Victoria, and St. Joseph's Hospitals simultaneously, with staff support remotely supervising and double reading all examinations on call. During daytime hours, while you're in hospital, it is possible to look up weekly duty rosters, which contain a schedule of all radiology staff work assignments, the specific services or stations that we're all working on during the week, with the URL links for radiologists at University Hospital and Victoria Hospital specified above. These URL links are specific to the hospital internal intranet and require a user ID and password that you will obtain to access the hospital websites, but can be used both at home or at work. If you open up one of these schedules, you'll see a PDF that looks like this, which is our weekly work schedule of all staff. The important thing to learn are the service designations on the left side, which specify the various services you may need the assistance of during the day. Very briefly, at my hospital site at Victoria Hospital, you'll see services such as MR body, covering MRI of the chest, abdomen, and pelvis, neuro CT and MRI, MSK for musculoskeletal, CT chest and chest biopsy, CT abdomen, abdomen biopsy, ultrasound and ultrasound obstetrics, interventional radiology, gastrointestinal fluoroscopy, and adult and pediatric general for general plain film. Every imaging department structure works differently, but usually it's helpful to try and understand how your local department is structured, so if you ever need help with a specific type of exam or exam of a body system, you know approximately which service to try and contact, if not who precisely to contact. You should also try to say to the phone operators that you're looking for example for the CT abdomen radiologist today at Victoria Hospital, instead of just saying I want to speak to CT. This will improve your chances at contacting the correct staff person. Here you can see the exact same schedule for University Hospital, and although the service names may differ on the left, it's very much the same idea, with different staff responsible each day for different services, or sometimes multiple staff assigned to the same service. When you're advocating for a scan or procedure to be performed, or to be performed more urgently, it's very important to have certain information available when you call radiology. Make sure you know your patient's PIN ID or MRN number, which is the specific hospital number of the patient you want to discuss, and is the way all exams we perform are organized. It will almost certainly be the very first piece of information we'll ask from you during any call or consultation. It's often helpful to have the patient's full name and date of birth as well to verify that we have the correct PIN number. As best you are able, try to have a good understanding of the clinical history of the patient any specific diagnosis or question your team has for the exam. It's also helpful to know if there have been any recent imaging tests already performed of the patient, as this is very often the very first thing we'll be reviewing early in the conversation. If you are ordering a complex examination such as a CT scan, MRI, or anything more than a general X-ray, you will commonly be asked whether the patient has any allergies, especially to intravenous contrast dye, what their last serum creatinine level was as a marker of how well the kidneys are functioning, any recent post-operative history, or MRI contraindications such as pacemakers or metallic implants that you're aware of. For any interventional procedure, such as performing a needle biopsy or insertion of a drain, you will be commonly asked routine blood work details such as hemoglobin levels, platelets or thrombocyte counts, or last INR numbers and last doses of active anticoagulation medications. These questions are routinely asked because if they do not satisfy certain thresholds, it may be too risky to perform a procedure until these values have been corrected or have improved clinically. It's important to understand that at any given moment, tens to hundreds of examinations are occurring in medical imaging simultaneously, so the assigned staff and residents are interpreting such studies in different orders of priorities, with priority given to ER or urgent inpatient examinations over others. However, if your clinical situation is urgent and you need a specific diagnosis confirmed, excluded, or an interpretation immediately, sooner than we will issue a final report, you always have the option of reaching a service during the daytime by asking the operator for a specific scan or shift type in radiology via the schedule websites that were shown to you earlier, or in the after hours asking the operator to, quote, page the radiology resident on call to discuss a specific exam. If a report has already been issued or signed off already and you wish to clarify or ask an additional question not addressed in the report, where possible, try and contact the specific individual that wrote or signed off the report directly, as they will already be familiar with the patient and the scan. Oftentimes, there may be a way to answer your question using the scan and images performed already instead of ordering another test, so always feel free to ask for clarifications. We also have the ability to issue addendums to reports to correct errors or address additional details you need formally documented. Hopefully, these general principles will help you in your future interactions with medical imaging. While there are countless specifics that you will gather more experience with as you proceed through your rotations, these general principles will always continue to apply now and well beyond your clerkship. If you have any further questions or at any time would like to seek advice or clarification of what was discussed in this presentation, please feel free to reach out or contact us. Your feedback as we develop future iterations of this clerkship transition curriculum are always greatly appreciated. Thank you very much.